This topic for discussion is associated ocular surface disorders in unhappy cataract patients. So cataract patient is truly satisfied only when his ocular health is very good. Many of times we come across patients who, in spite of having an uneventful cataract surgery, still complains of pricking sensation, stinging sensation, some foreign body sensation, even though there's no obvious ocular surface pathology. These are the patients who have unhealthy ocular surface. And these ocular surface abnormalities are commonly seen in elderly population, and fortunately or unfortunately, it is these subcategory of population that presents to us for cataract surgery. And this not only affects patients symptomatically but also affects their refractive outcomes. So why does ocular surface get affected following cataract surgery? Various factors like repeated drying and irrigation that occurs throughout the procedure of the surgery, various eye drops that are instilled, the phototoxicity from the light of microscope, surgical trauma, be it placing a speculum, making an incision, holding conjunctiva for support, or placing a flak suction ring, all cause microocular trauma which damages corneal epithelium and goblet cells, resulting in dry eyes. So again, the literature suggests the same. And how do you work up these patients on the lines of ocular surface? We start with symptoms. We ask the patients how they feel. A simple method is to offer them a OSDI questionnaire that has simple subset of questions regarding the symptoms, and then grade them accordingly as normal, mild, moderate, and severe. So once we understand the symptoms, the next thing is to examine them on slit lamp, look for obvious pathologies like lid margin abnormalities, any foamy discharge suggesting MGDs, telangiectasias, or obvious evidence of dryness. Bedside investigations like Schirmer test and tear film breakup time can also be helpful in assessing the ocular tear film surface. So why this has to be done? Studies have again pointed out that tear film breakup time and Schirmer tests are drastically affected following cataract surgery. Not just immediately, even after 1 month, it seems to be affecting the tear film breakup time. So once we have seen the ocular surface clinically, we'll dig a bit deeper and go into imaging. Meibography, I think, should be incorporated in every setup because now that we practice premium cataract surgery, even if one does not have sophisticated machines, one can always look at meibomian glands through simple AR machine and look for any gland dropouts or meibomian gland abnormalities. Why? Again, because a lot of patients presenting for cataract surgery do have significant meibomian gland dysfunction, and many of them are in fact asymptomatic, and us doing cataract surgery on them is just worsening the MGD. So MGD will cause definitive ocular surface discomfort and suboptimal visual outcome, resulting in unhappy cataract patients. Now that we have all incorporated aberrometry in our premium practice, the most commonly used aberrometer, that is the iTrace, has in its latest version something called as tear film analysis. It scales the ocular tear film objectively on a scale of 0 to 10, 10 being good and 0 being the worst. It also gives an objective tear film breakup time, and it is called as topo breakup time, which is the first point at which the Myers get disrupted. So the next most common ocular surface parameter that gets overlooked is epithelial thickness. Epithelial thickness is a surrogate marker for ocular surface health. Irregular epithelium can result in poor healing and nerve regeneration and ocular discomfort. Now that we do OCT screening for all patients, a simple OCT has an epithelial thickness mapping which can indicate irregular epithelium to take over such category of patients. Now that we have imaged how to treat these patients, first categorize them symptomatically as patients with asymptomatic, mild and moderate symptoms or severe symptoms. Then depending on the imaging, if they do not have any gland loss, they do not have any irregular epithelium and tear film index is quite good, then it suggests a simple aqueous deficient dry eye, and all we can do is lubricating drops. Next, if there is some amount of gland loss, let's say 25 to 50% with a regular epithelium but a tear film index relatively low of around 5 to 8, then along with lubricating drops, we can add topical corticosteroids and cyclosporins, because ocular surface inflammation is an overlooked topic when it comes to ocular surface abnormality, and we need to take care of that as well. We even have to start them on omega-3 fatty acids, which would improve the meibomian gland outflow. Suppose they have significant gland loss, more than 50%, with irregular epithelium and tear film index less than 5, then these patients will not just improve with topical therapy and will need a procedural dry eye therapy. What are procedural dry eye therapies? We'll look into that in future slides. So in a gist, ask the patients to maintain lid hygiene, start them on preservative-free eye drops, and review them on regular intervals as per your need. In case they do not improve, then treat them with procedural dry eye disease therapy. To add a quick note on them, it may be light modulation therapy or intense pulse light therapy, or something with mechanical effect as well, such as lippy flow. All these does is improve meibomian gland outflow and hence enhances tear film stability, in improving ocular surface and better patient outcome. So among these, lippy flow, usually we need to wait for a month or so because this has small pressure effect. So early post-op patients might not be good for them to undergo lippy flow patients. So overall, ocular surface disorders do take a huge chunk of patient satisfaction away from your patients, and they can exist in the absence of any clinical evidence signs. Optimizing ocular surface is very vital for enhancing post-op outcomes. We need to tell patients that all these tests are not being done to overburden them, but rather to enhance their refractive outcome and their symptoms. So treatment should ideally begin in the pre-operative phase, because we've all seen that meibomian gland deficiencies are significantly present in cataract patients, and once we do surgery, we just overburden them with more ocular surface abnormality, and we should treat them pre-operatively to prevent such things from happening. Thank you all.
Thank you, Dr. Abhishek, for a